there's the light. That'll work. Good. All right, so we're inside. I hope the lighting's better. I'm with, again, Dr. Mell Duggan. Mell, appreciate you doing this. Mell is a urologist, and I thought we'd talk a little bit today about, common urology problems. Kidney stones would be something I would think you commonly see.
It is.
We're in isn't this the Stone Belt?
Stone Belt, and this is the start of the stone season.
Oh, really? You have a stone season?
Yeah. The dehydration that takes place in the hot months, people grow stones, and then in the fall they pass them. So
that's when they express themselves.
Yeah, it's not a huge bump, but we see a lot more than, say, the dead of winter or spring.
And so there's less stones in cooler climates?
That's right.
Interesting. Yes. I never realized that this is why we're in the Stone Belt, because it's a hotter climate.
Right. And the most important thing one can do to prevent stones is to drink lots of fluids. And so the evaporation from sweating, the urine becomes concentrated and stones form. And there's more urologists in the southeastern United States than anywhere else in the world. The southwest part of the country, low humidity, they don't have as many stones.
Interesting. I personally love, and you may not, but I personally love these IV hydration centers that have popped up all around. At least in the South, I see them in a lot of cities now. Do you know what I'm talking about?
Not really.
So there are these places where you're dehydrated and you just pay $100 and they pop in an IV, give you some fluids, and you're on your way. A lot of people are using them, like, I guess, to treat hangovers and stuff like that. But if you're dehydrated, there is no better way of getting rehydrated. And it's kind of, to go to the emergency room and all that they're around, believe me.
They're not going to put me out of business, are they?
I doubt it. I doubt it. But stones, well, tell us about the pain with stones. Tell us about preventing stones. I get the feeling, because I've never had a stone, so I don't, but people tell me it's the worst pain, and it rivals, I guess, childbirth.
Right. Well, most women who've had children, natural childbirth, will tell you the stone is worse. But believe it or not, the stone doesn't cause the pain. It's the blockage from the stone. So I've got a guy I'm operating on Friday who's got a 2-centimeter stone. That's an inch. He doesn't even feel it because it's in the kidney. It doesn't block anything. But also...
So why are you operating on it?
Because it's so big, it'll do damage to his kidney.
Okay.
Then I have other patients who have a small stone that leaves the kidney and goes down the narrow passageway between the kidney and the bladder called the ureter. And when the stone gets stuck in the ureter, upstream from that, it's under pressure and it stretches the ureter and the kidney. So even if the stone is down low, you'll feel it in the kidney because it's stretching. But the stone can move and the urine gets past stone immediately, the pain goes away. So that's one of the hallmarks that you have a stone. Your pain comes and goes. It's like Dr. Goodman said, it's the worst pain you've ever had. You usually are nauseous or you throw up, and it feels like a knife going in you. I've had one. I woke up in the middle of the night with my first stone in New York City. I thought my wife had stabbed me. It was terrible. And
were you a resident then?
No,
what was going on then?
It's a great story. Let me just say this. So I had been doing triathlons, and I got real dehydrated, and I formed 5 stones. Never had them before. Never knew I had them. First one hit me in New York, and I was at a meeting. So the meeting was
you were at a urology meeting?
At a urology meeting. So I decided I'll go to the hospital to the meeting, and if I hurt real bad, I go to the emergency room. I knew what I had. Uh-huh. So it's dark. Dawn hasn't come. I get a cab, and the guy doesn't speak English or claims he doesn't. And since there's nobody on the streets, he hauls. He's taking the corners on 2 wheels, and I'm nauseous. And I said, "Slow down, I have a kidney stone." He goes, "No English." And it's going like that and everything. He's got a turban on his head. We're going in there. He goes around the corner. I said, "If you don't slow down, I'm going to throw up all over your cab." He understood me fine. But anyway, I get to the hospital and was doing better. Again, the pain can come and go. All of a sudden, it hit me again. And I stood up in the middle of the meeting, just grabbed myself, staggered out, and a Korean doctor saw me stricken, and he was asking me all these questions, and I couldn't answer him. I hurt too bad. That's how bad the pain was.
Wow.
And you can't quit moving. That's another hallmark of pain. You move. Most things that bother you, like appendicitis or whatever, you don't want to move. It hurts.
Back
pain.
Back pain, you don't want to move.
Anybody,
you cannot get comfortable with back pain.
Kidney stones, about the only thing I know that you can't sit still. In fact, I had a farmer from North Alabama came to see me, and I said I had a bad night. I go, it was bad. He goes, yeah, I wallered twice. Like a pig wallering.
See, that went right over my head, but I'm not from here originally, so you got. Is there a question in there, Seth?
Not quite yet.
Okay.
We got some more viewers.
All right. So if you're just tuning in to Doc Talk Live, I'm with Mell Duggan. If you haven't figured out, he's a urologist, and he's sharing his personal kidney stone story. So
it illustrates very well what one feels like.
And then, so what did you do? Did they just have to give you a shot of morphine, or what happened next?
Yeah, I got to the emergency room, and it had stopped. I was doing okay, so I didn't get Dilaudid or morphine, a narcotic. I got an anti-inflammatory agent called Toradol, which is really good, and my pain got better, and eventually the pain subsided enough. I went back to Birmingham and had ureteroscopy. My partner went up with the scope through the bladder up to the stone and lasered it and took it out.
So how do you decide? There must be more than one. There's lithotripsy. That's what's going through my brain. How do you decide what procedure to do?
Well, first to decide, are they going to pass it or not? You don't want to operate on somebody that you think will pass it. But in general, stones lower in the ureter, near the bladder, you go with a scope called a ureteroscope and laser it and take it out. Stones up in the upper ureter in the kidney, if they're small, you can break them up with lithotripsy, which is a sound wave that enters the body focused on the stone and breaks it up. So you got to be able to see the stone. There's some stones that you can't see on an x-ray. They're made out of uric acid, and you would have to squirt some dye from the bladder to show the stone so you could do that. The other alternative would be to take a flexible small scope and go all the way up into the kidney and break it up. And there's pros and cons of each one. And then for big stones over 2 centimeters, the best treatment would be a percutaneous nephrolithotomy, where you put a needle through the back into the kidney, put a balloon in there, stretch it out, put a straw over the balloon, take the balloon down, then operate through the straw with a miniature jackhammer or a laser.
We need to get into the OR and show them the percutaneous, what's it called?
Nephrolithotomy.
Nephrolithotomy.
It's 3D with fluoroscopy. It's very similar to what you do with the back. When you do your injection.
Fascinated by that. I don't want to take that over from you though. Is there any way to prevent these things?
Well, usually you can.
And are they genetic? Are they genetic?
They can run in families, and not everybody has the same cause for the stone. So to evaluate why a person is getting a stone, you need to analyze the stone. Mm-hmm. They either pass it or you take it out in surgery and then analyze what kind it is. In Alabama, the vast majority, 90%, are calcium oxalate stones because of dehydration. In Minnesota, about 50% are uric acid. They don't have the same type of stone that we have down here. And then once you know what kind of stone it is, save the urine for 24 hours, analyze what's in the urine. One of the more common problems we see are low citrate levels in the urine, and that's easily replaced with a supplement called potassium citrate. People ask me, well, couldn't you just drink a lot of citric juices and everything? It would be the equivalent of 7 lemons a day, and that would be horrible.
That'd be tough. That'd be tough. So dehydration, preventing dehydration would be important in the summer. So drinking lots of fluids. Is there anything else that would prevent?
Well, in general, and you'd have to do a 24-hour urine and a stone analysis to really figure out what works for a certain person. But in general, fruits and vegetables are better than animal protein, and low salt is good. There's an exchange in the urine of salt and calcium, and if you have too much salt, without going into too much detail, you end up with more calcium in the urine that combine.
Well, I love all those things: fruits and vegetables, and proteins and salts. So, unfortunately, I don't have them. Let's push on. Are there any questions that we need to tackle before I push on?
Not so far.
Good.
Carrie says it's very interesting.
Okay, good. Thanks, Carrie. I appreciate. I guess you can hear me now too, Carrie. I appreciate that. Hematuria, blood in the urine. Okay, tell us a little bit about that. I guess from a layperson's perspective, if I saw blood in my urine, I would panic, or certainly be, very concerned. Just like seeing blood in stool. So tell us a little bit about that.
Well, good that you would be afraid of it. I've seen patients with very advanced kidney cancers that you ask them, well, did you ever have blood in the urine? Well, 2 years ago I did, but it didn't hurt and it stopped, so I didn't worry about it. And so if you don't remember anything else from today, if you have blood in the urine, get seen. It can be something innocuous, or it can be something that could save your life if you go and get it checked out. So the list is fairly long. And depending on what age you are, if you're a male over age 50, the most common cause would be prostate enlargement. As the prostate grows, it pushes veins near the surface of the prostate and they can bleed easily. It's no more dangerous than a nosebleed unless you have clots and it blocks you up, but needs to be evaluated. Kidney cancers, bladder cancers, rarely prostate cancers can cause blood in the urine. Infections and stones would be the main ones.
So if I came to see you, let's say, about blood in the urine, and I have seen Mel before about other things, which we will leave that for the audience's imagination, but the workup, I imagine, would be...
Well, first you as always, take a history, examine the patient, and look at the urine. A lot of times you can, if the urine looks infected, you're going to do a culture, start on antibiotics, and wait on the evaluation until the infection is cleared up. But in general, you'd want to get a CT scan of the abdomen and pelvis, and you'd want to do a scan without dye to look for stones, because if you give the dye and the stone look the same. So you do a CT scan of the abdomen and pelvis with and without intravenous contrast. And then, just as a CAT scan can't show pathology in the colon, and so you have to undergo a colonoscopy, similarly, you need a cystoscopy to tell. You can miss bladder cancer and things if you just rely on the CT. So it's both. And in some cases, we do a urine cytology, but that's rare. The cytology looks for cancer cells suspended in the urine.
Okay. So I think your message, if I'm hearing you correctly, is blood in the urine is something to take serious.
That's right.
Okay. Very good. If you're just tuning into Doc Talk Live, I'm with Mel Duggan, and we're talking about various common urology things. I think the last thing we'll cover is maybe BPH.
Yes, BPH stands for benign prostatic hyperplasia, which is prostate enlargement. It actually begins in men in their 30s, but it takes a while in most men to get big enough to cause problems. So before I explain that, let me just go over what the prostate does, because most people don't know that. It's a gland that sits beneath the bladder, and it creates a fluid that helps the sperm survive inside the woman's reproductive tract long enough to impregnate the egg. So if you're not trying to have children, it grows and blocks you. It can get infected, or it can form cancer.
So once you've reproduced, you don't really need your prostate anymore.
No, it does you no good, but allows me to make a living.
Okay. But taking it out is complicated, I would think.
It is, and you would remove it for cancer without going into a lot of detail. And the state of the art for that now is a robotic laparoscopic procedure. We're a group of 24 urologists, but there's half dozen that do that. It's complicated, and you want people doing a lot of those to get really good at it. I don't do that.
Why does the prostate enlarge just in general?
No one knows, and in about 10% of men it never does. It does enlarge with testosterone stimulation, and so like eunuchs in the Middle East, they never had prostate enlargement. You have to have testosterone for it to enlarge, and some of the treatments we have now are based on that. There's drug finasteride or Avodart, which block the uptake of testosterone into the prostate and shrink it. And then there are other drugs that open the prostate. The prostate is shaped like a donut, and one pees through the hole in the donut. So if the donut swells, the hole shuts off, and that's the main problem. There's drugs that block the nerve impulse called alpha blockers. Tamsulosin or Flomax is one of the common ones. Another one is Rapaflo, and they open up the bladder, neck, and prostate, but they can only do it so much. Sometimes surgery is needed, and there's different surgeries. Traditionally, there was a transurethral resection of the prostate, which was an electrical wire that would cut out and remove the prostate. Nowadays, that's still done, but mostly with a bipolar electrical device that shoots a very powerful current between a small space, and it vaporizes the tissue rather than cuts it out. Vaporization is the physical property of going from a solid to a gas. So when I'm doing this operation, I'm underwater. As I paint this instrument across the prostate, bubbles form. Those bubbles used to be the prostate, but we joke in the operating room that bubbles don't bleed. There's a lot less bleeding doing that than the traditional transurethral resection of the prostate, which I've done thousands of those back in the day. Big catheter, stay in the hospital 2 days, a lot of blood. Now, most of these go home the same day.
Unbelievable. When did that become the standard?
In the last 10 years.
Wow. Well, if you catch the rebroadcast of this, I'm with Dr. Mell Duggan, Doc Talk Live. If you can type in some comments, also shows you'd like to see, that would help me out. I'll try to find those guests who are expert at that. Mel, I want to thank you for coming on.
My pleasure.
How do they find you? Urology Centers of Alabama. Is there a phone number?
Yes, 205-930-0920, and Urology Centers of Alabama. Google it. We have a website that has a lot of good patient information and videos.
I appreciate it. Anything that we need to, any business we need to tend to, Seth? Are we good?
Oh, not yet.
Okay, all right. I guess we'll just leave it there then.
Sure.
All right.
Any particular diet someone should follow if they have calcium stones?
Yeah, well, hydration is the main one. Cut down on sodium. Soft drinks are especially bad. They're loaded with sodium. Most people don't realize that. And the carbonation fills you up, so you don't want to drink water. You're full. So soft drinks are bad. Try to get your protein from vegetable sources and from dairy products as opposed to animal products. And then fruits and vegetables in general are good. But don't worry about all that. The water, taking in more fluids is so much more important than those other things. I almost hesitate to tell patients that because they do that, still get stones because they didn't do the most important thing, which is more water or anything wet.
Okay. So, need water and blood in the urine is bad. Okay. Got it. All right. Is that it, Seth?
Sure. And if someone were to have like a urinary tract infection, they say, hey, I think there's some blood in my urine. Is that a good reason for them to go ahead and be seen immediately? Or?
Oh yes, yeah.
Mm-hmm. Okay.
Yeah, don't wait. If you any blood in the urine needs to be checked. It's not an emergency, but if you're having burning or pain or you feel like your bladder's not emptying, get there right away.
Okay. We can hit finish, I think. Let me see.